I work in politics. I live and I breathe politics. And politics, let me tell you, can really, really suck. Perhaps this is obvious or implied. It seems on a daily, hourly, and minute-by-minute basis, we're deluged with negative news about politics. The issue of healthcare, of course, is no exception. And perhaps it's an issue where this is even more pronounced. Why? Because healthcare is politics that is literally on our body. It's the government on us, close to us, near us, even in some cases, in us. This creates immense political and personal challenges. So why the hell do I work in politics? For one simple reason. Contrary to what we've come to believe, on a large scale, politics is perhaps the best vehicle to improve people's lives and improve their care. And this fact is exponential for those living with serious advanced illness and facing the end of life. Take Linda. Linda is a working mom, her son not yet out of high school. Linda is caring for her parents, both of whom are suffering from Alzheimer's and have less than a year to live. Take Phil. Phil's a physician who practiced for over 30 years in Johnson City, Tennessee. But still, Phil could not have imagined how hard it was to have that conversation with his terminally ill wife at her bedside, holding her hand. Take Johnny. Johnny's the son of a mother and father with two terrible diseases, cancer, mother with cancer, and a father also with Alzheimer's. And Johnny saw the importance of thinking about your own care options when you are of sound body and mind, as he did with his parents. And finally, take Ted, or Teddy, as many of us know him. Teddy lived and worked after being diagnosed with terminal brain cancer, wanting to leave his mark on those he dedicated his entire life to serve. His mantra, while still working and dying, "Aren't I lucky?" So what do each of these individuals have in common? Why are their stories unique, but also common to us all? Linda, Phil, Johnny, and Teddy are all members of the United States Congress, United States House, or United States Senate. It's true, actually, politicians are humans too. I know it's hard to believe. But this notion that politicians, regardless of the legislative body in which they serve, federal, state, or local, have personal end-of-life stories that cut through the political toxicity and challenges we face as a country. It's this notion that I've found in the halls of Congress can be the most powerful and can change the lives of millions of Americans. I have a story too. To me, this issue is deeply personal. This is my mom. This was taken from Facebook yesterday without permission. So this isn't being filmed, right? So my mom has cared for hundreds of individuals in hospice for the past 35 years. She's the heart side of my brain. My dad was a physician and a pathologist on the left here, and a scientist. He's the technical side of my brain. This led to some very interesting dinner conversations growing up. I call them conversations now, they were arguments about death. It's these two opposing viewpoints of a dying patient. Not a patient, my mom would teach me, but a person. Seeing the person honors their dignity and their quality of life, not just their medical care. My dad, on the other hand, taught me just how much could be done, the miracle of modern medicine, and how far medicine could actually extend life. It's my parents, right-handed, left-handed, science and spirituality, life and death that led me to palliative and hospice care, the idea of alleviating suffering through health and human care. And the idea that if we redesign our healthcare system, redesign those built-in incentives that we can achieve the promise of palliative care and hospice care, and that care could always be responsive to one's goals, values, and wishes for all people, not just those who are dying. Unfortunately, in America, we do not receive the best end-of-life care possible. I call it, we all have different terms for it, I call it the big gap. On the left is what people want, and on the right is what we typically get. We want to have our care coordinated in the home as the primary setting, yet all too often we're recycled in and out of the hospital. Study after study shows that our healthcare system still prioritizes volume over value of care. Don't we all want our health professionals to communicate with one another, especially when we're seriously ill? Next, we want to have our pain managed and receive comfort care, yet many people who are dying receive unwanted, ineffective treatments. Another study showed that 89% of individuals said that their healthcare providers should talk about end-of-life care. Only 17% of those talks actually happened, and 90% of physicians, nothing against the physicians in this room, ever brought it up. 90%. Next, they want to be at home with their family and loved ones, yet all too often, and typically, we die in the hospital and sometimes even in pain and isolation. Studies performed right here in California asked, where do you want to die? 70% of individuals want to die at home. 68% in California do not. This is the big gap. And finally, the seriously ill, as BJ was saying earlier, they don't want to be a burden on their loved ones. This is just a sort of a shocking notion to me, but study after study after study shows that it's the number one issue that people think about when they're dying. Yet we know that high medical costs at the end of life can impoverish families, and it costs our nation hundreds of billions of dollars in unnecessary spending. This is the gap that we must close. Finally, Dartmouth Atlas teaches us that there are geographic disparities as well in the United States, and that there are best and worst places to die in this country. Why is it that 71% of individuals in Ogden, Utah die in hospice, yet 31% do in Manhattan? A full 40-point spread. Why is it that ICU deaths in Cedar Rapids, Iowa are almost 4 times that of Los Angeles? Again, we must close these gaps in order to honor individuals' dignity and to ensure that they get the best care possible. Policy and politics do offer solutions to close this gap. So first, policy. In the past several years, dozens of bills have been introduced in Congress to improve the lives of those with advanced illness and facing end-of-life care, more than ever before. It's my great privilege to work with many of those folks in the room and across the country on this legislation. Some of them have even progressed and already become law. Yes, we're making progress, and yes, there's hope. For example, Medicare now places a value on advanced care planning by paying physicians and health professionals for a conversation about end-of-life wishes. Advocates fought for decades for this simple policy solution, yet politically charged issue. One would think that the death panels are indeed dead. Bipartisan legislation has been introduced to deploy new models of care similar to hospice, but upstream from hospice for those with advanced illness. Imagine getting supportive palliative care from an interdisciplinary team in the home setting months, if not years, before hospice eligibility. Payers in the commercial marketplace and Medicare Advantage marketplaces are experimenting and investing in this kind of care. Medicare itself should be next. The Medicare Choices model, which was referenced earlier, shows promise by allowing for curative and comfort care to be offered at the same time. But this model only applies to those who are currently hospice eligible. We must go upstream from hospice. Hospice is the original person-centered care model. Bipartisan legislation was introduced to train our workforce in palliative care. We need more palliative care soldiers in this country. Let's invest in our workforce to ensure that health professionals, not just in hospice and palliative care, but all health professionals have basic training in end-of-life care. Shouldn't that be the norm? And finally, bipartisan legislation passed the Senate unanimously just a few short weeks ago that would improve and pay for better care coordination for those with multiple chronic conditions. This legislation included a seminal study that looks at longitudinal care planning for those at the end of life. This is just a sample of the bipartisan progress we've made as a country. Yes, we're making progress, and yes, there is hope. Now, politics. Yes, politics can suck. But in this case, politics can be both a solution and an inspiration. You've heard the phrase that all politics are local. Well, in healthcare, all politics are personal. In health, how do we navigate the complicated politics of advanced illness and end-of-life care? We use personal stories as our guiding beacon. Just 1 year ago, the Senate Special Committee on Aging held a bipartisan hearing led by Senator Sheldon Whitehouse, a Democrat from Rhode Island, and Senator Susan Collins, a Republican from Maine. A guy by the name of Dr. Atul Gawande, maybe you've heard of him, was the lead witness at the hearing. The hearing was about end-of-life policy. Guess what? Within moments, it was clear this hearing wasn't about policy. This hearing became about stories. There was not a dry eye in that committee room, including members of Congress, including me. I'm a crier. I even think I saw Atul get a little misty. Yes, even in committees in Congress, we have the opportunity to humanize the issue of end-of-life care. Many of the members who support this legislation do so not for political reasons, but because of their stories. Tori's story, my story, your stories, our stories. But it's more complicated than that when it comes to politics. If personal stories are our guide, our green light across the bay, our key to unlock that conversation, then managing the process, the political process, is the strategy. Process is the roadmap for success. We have many tools in our tool belt. Lawmakers feel all sorts of pressure and want to create change, from constituent outcry to big donors, from their own political aspirations to putting political points on the board. Lawmakers have problems that need to be addressed, and the best possible end-of-life care can be a solution to solve those problems. One of these is fiscal in nature, and it was touched on earlier. The problem of high unsustainable costs in the Medicare program, largely attributed to too many expensive tests being ordered and a growing baby boomer population. We know the Medicare Trust Fund will be insolvent, for example, by 2029. We know that approximately 5% of Medicare beneficiaries account for almost 40% of the costs in Medicare, many of them at the end of life. We also know that Medicare spending in the last year of life has doubled over the past 15 years. Addressing costs at the end of life is the unspoken, the quietly whispered issue in end-of-life care. Politically, costs at the end of life are the third rail. Lowering costs must mean rationing, right? It must mean that the government is taking something away. No. It makes no difference to me, no difference to Congress, no difference to Medicare, what you want in terms of your treatment, or none at all. You do you. When done right, when care is provided in accordance with one's goals, values, and wishes, when care takes into account the conversation, supports the family, is provided in the home setting, and avoids the unnecessary crisis care in the hospital, guess what? It saves money. And more often than not, when more care is provided in the home setting or the appropriate setting, costs are still lower. That's the care that my mom wants. I think it might be the care my dad wants. We're still talking about it. So maybe, just maybe, quality advanced illness and end-of-life care is the solution to the sustainability of our cherished public programs like Medicare, not just for now, but for generations to come. Yet serious challenges do still remain. When asked, does the Affordable Care Act allow a government panel to make decisions about end-of-life care for people on Medicare. A full 60% said yes, or I don't know. The I don't know is 5%. Indeed, the death panels are still alive, and this is our challenge. So that's where you come in. It's your stories that will be the engine that will drive politics for better advanced illness and end-of-life care, that will kill that death panel, that will normalize the conversation in politics and well beyond. It's your stories that will break this logjam, that will neutralize the toxicity. Keep talking, keep sharing, and keep telling, because if you do, if we do, we will have better end-of-life care in this country, and politics might just suck a whole lot less. Thank you.